In this video, dissection of the forearm will be demonstrated. This work was produced by Dr. Carlos Andres Suarez-Quian and Dr. Joel Walensky. Dr. Suarez-Quian is the narrator of this video. Previously, we stated the specific size of the arm. We do the same now for the forearm. The forearm represents a part of the upper limb that extends from the elbow to the wrist. The forearm contains the muscle bellies of the muscles that supply power to our fingers, both for flexing and extending the digits. Let's begin the dissection of the forearm. The deep fascia of the forearm provides a tough and competent sleeve to confine the muscles of the forearm. Here, as in other body regions, increased pressure within the sleeve can cause pain and muscle weakness. This is referred to as compartment syndrome, and if not treated acutely, the patient can and will lose the forearm. For example, look up the recent story of the PBS reporter Miles O'Brien, who had his left arm amputated above the elbow after a seemingly insignificant injury led to compartment syndrome. A camera case fell on his arm, and after a few days, the compartment syndrome resulted in gangrene of the arm, requiring the amputation. To clearly reveal the muscles of the anterior forearm, the deep fascia must be carefully removed. Removal of this fascia without damaging the underlying muscles and surrounding neurovascular structures requires careful and tedious dissection. Once the deep fascia is removed, the elegant arrangement of the anterior forearm muscles is revealed. Some of these muscles provide for wrist movement, whereas others are referred to as the extrinsic digital flexor muscles because they are extrinsic to the hand but facilitate powerful finger flexion. The brachioradialis is an interesting muscle because it both flexes the elbow and wrist but also can pronate and supinate the hand depending on the initial position of the hand. Neutral position for this muscle is in the thumbs up position. The pronator teres pronates the hand and flexes the elbow. The flexor carpi radialis is a powerful wrist flexor and abductor. The palmaris longus is the flexor of the wrist, but is missing in up to 10% of the population, and it can be missing in one forearm and not the other, or it can be missing in both forearms. Lastly seen in this view is the flexor carpi ulnaris, which flexes and adducts the wrist, and along with the flexor carpi radialis are used to wave the hands when waving bye-bye. The median nerve, which contains fibers from both the medial and lateral cords of the brachial plexus, innervates most of the muscles of the anterior forearm. It is often partially hidden at the wrist by the tendon of the flexor carpi radialis. As the median nerve travels from the forearm to the hand, it passes through a compartment known as a carpal tunnel. The approximate area is indicated by the blue square on the hand, and a dissection of the actual carpal tunnel is shown in the inset. The median nerve can be compressed here, producing carpal tunnel syndrome, which is really simply a compression syndrome in this region. Continuing the dissection by removing some of the superficial muscles exposes the superficial flexor of the digits, the flexor digitorum superficialis. And also, we can now demonstrate the continuation of the median nerve along the entire length of the forearm. Note how the nerve tends to flatten as it reaches the wrist and enters the carpal tunnel. This phenomenon is not typically shown in artistic renditions of the nerve. The median nerve can also be entrapped as it enters the forearm in between the two bellies of the pronator teres that we cut earlier. The consequences here are worse than for carpal tunnel because both the thumb and the forearm muscles will be affected. Reflection of the most superficial forearm muscles reveals the flexor digitorum profundus. Here, I am stretching the tendons of the profundus to demonstrate their individuality as tendons to the different digits. Together, the superficialis and profundus enable strong finger grip strength. When the flexor digitorum superficialis is further reflected, the ulnar nerve and artery can be seen to meet as they run in the plane between the superficial and deep intrinsic digital flexor muscles. Once together, the ulnar nerve and artery eventually enter the hand, but do so by passing external to the carpal tunnel. Thus, the nerve is not affected in carpal tunnel syndrome, but is affected in similar compression syndrome referred to as ulnar tunnel syndrome. It is also called Guillaume's canal syndrome. The ulnar nerve can also be compressed as it passes posterior to the medial epicondyle, a condition referred to as cubital tunnel syndrome. Also visible in this slide is a flexor pollicis longus, which flexes the pollicis, that is, the thumb. Focusing on the blood supply to the forearm, the brachial artery is seen here as it bifurcates into the radial and ulnar arteries. Note that where the ulnar artery passes deeply, the radial artery remains relatively superficial. In the image, however, the superficial location of the radial artery is masked by the muscles that were reflected to demonstrate its formation from the brachial artery. The relatively superficial and deep locations of the arteries clearly facilitates providing a blood supply to both the superficial and deep anterior forearm muscles. The complete extent of the relatively superficial path of the radial artery in the forearm is now shown in the slide. Also, I am reflecting the flexor digitorum profundus and the flexor pollicis longus muscles in order to demonstrate the pronator quadratus muscle, a deeply located muscle that looks like a square and that acts to pronate the hand. We now turn our attention to the extensor side of the forearm. Again, the muscles located dorsally in the forearm are encased by a strong layer of deep fascia. The muscles on this side of the forearm extend both the wrists and the fingers. Here again, the finger extensor muscles are referred to as the extrinsic digital extensor muscles. Also, labeled here is a brachioradialis muscle, which is well seen from a dorsal perspective and thus can again confuse students on practical exams. The extensor retinaculum is a thickening of dorsal forearm deep fascia that acts to maintain the tendons of the extrinsic digital extensor muscles in proper alignment and grants them mechanical advantage while extending the digits. The extensor digitorum muscle is a primary extensor muscle of the fingers. Note how the tendons span out from the muscle belly. We have much less control of the extension of individual fingers than we do of flexion of the digits. The extensor carpi ulnaris extends and adducts the wrist and works antagonistically to the flexor carpi ulnaris. Whereas there is a single flexor carpi radialis, there are two extensor carpi radialis muscles, a longus and a brevis. They act to extend and abduct the wrist. Also on the dorsal side of the forearm are three muscles referred to as the outcropping muscles of the thumb, because that is the way they appear. Although at this stage of the dissection, only two of the muscles can be distinguished with certainty. The three thinner outcropping muscles are the extensor pollicis longus, the extensor pollicis brevis, and the abductor pollicis longus. These muscles border a region of the proximal dorsal thumb called the anatomical snuff box. Snuff is dry tobacco, and this anatomical box provides a perfect depression for the placing of snuff prior to inhaling it. More importantly, from an anatomical perspective is that the radial artery passes through the anatomical snuff box, and also that pain in this region is often associated with a fracture of a carpal bone. The brachioradialis is again seen from this dorsal view in a small muscle that wraps around the radius, the supinator muscle. The supinator muscle, as its name implies, is a supinator of the hand. Exploring the interval between the two muscles reveals a radial nerve as it crosses the elbow joint. Focus your attention on the radial nerve as it crosses the elbow. The radial nerve can be entrapped at this location from repetitive action. The radial nerve then splits into a deep and a superficial branch. A finished dissection of this region is now shown to better demonstrate the separation of the radial nerve into a superficial and a deep branch, and how the deep branch then dives deep to the supinator muscle. The deep branch of the radial nerve then passes to the interosseous membrane to reach the dorsal aspect of the forearm. Upon doing so, it changes its name and becomes a posterior interosseous nerve. Either the radial, deep branch of the radial, or the interosseous nerve innervates all of the muscles of the dorsal forearm. Unfortunately for students, these nerves are often used nonspecifically by both anatomists and clinicians, which makes initial learning of the innervation of these muscles very confusing for students. Specifically, whereas, for example, technically, the posterior interosseous nerve innervates the extensor digitorum, many sources will list its innervation as the radial nerve. Clinically, this makes some sense because a proximal lesion of the radial nerve, such as one that occurs with a fracture of the shaft of the humerus, will result in paralysis of the dorsal wrist and finger extensors, which manifests as a flexed wrist and a hand, known as a wrist drop. This now concludes this video presentation on the forearm.